Hi everyone, welcome. We'll just give a couple minutes for everybody in the waiting room to be able to get on, but we look forward to getting started in about 30 seconds. So thank you everybody for joining us. We know people may still be trickling in, but we're really thrilled that you're here. So good morning, good afternoon, good evening to our colleagues in Lesotho. My name is Mark Brender, and welcome to PIH Canada's International Development Week webinar. We are so glad you're able to join us. Before we start, I'd like to acknowledge that I'm in Toronto on the traditional territory of many First Nations, including the Anishinaabe, Chippewa, Haudenosaunee, Huron-Wendat, and Mississaugas of the Credit. We are grateful for their stewardship of these lands and acknowledge our responsibility to be in relationships of humility and solidarity with Indigenous people today living on these lands. So we are talking today about strengthening last mile health systems using a rights-based approach, particularly in Lesotho and Mexico, 2 of the 11 countries where Partners in Health works, and how the global community can better support their efforts. As many of you know, Partners in Health accompanies communities and governments to build strong health systems, and we truly do have 3 experts in the field with us today. Dr. Melino Ndayizigiye, Executive Director of Partners in Health Lesotho. Dr. Valeria Macias, Executive Director of PIH in Mexico, known as Companeros and Salud. And Dr. Ryan Meili, a board member for PIH Canada, a family physician normally working in either Saskatoon or in Indigenous communities in northern Saskatchewan, but coming to you today from Macias, Lesotho, where he is currently serving as a clinical volunteer with Partners in Health. So we will talk first for about half an hour, leave lots of time for your questions. If you'd like to ask a question, please type it in the chat, and we will try to get to as many as we can during the Q&A portion. The webinar is also being recorded, and we will be sharing it after the event. For those of you who would like to watch the webinar with captions, you can click on Show Captions at the bottom of the screen. Select your preferred language under My Caption Language. There are many options available, and the full transcript is also available as the second last option, or should be in the list on your screen. And so with no further ado, let's dive in. And I'd love to start first with Val. And so Val, thank you again for being here and making the time. As you know, at Partners in Health, we have a saying, the patients are our bosses. And our patients' needs really give us our marching orders. So maybe you can start by sharing where you work, the size of your team, and then give us a short description of who your bosses are. Who are the people you are serving, caring for, and accompanying in your last mile, and what are their lives like?
Well, thank you, Mark. It's a pleasure for me to be here and share part of the work that we do. We are based in Chiapas, which is a state in Mexico in the border with Guatemala, so very south in Mexico. And we are a team of around 200 people, more or less. And we work in an area called the Sierra Madre of Chiapas, which is a mountainous region, a very large mountainous region. And it is a moist forest where we are. So we have beautiful, beautiful views. But at the same time, it's a place with very difficult access. There is usually no roads available. So, and it's a place because it is a moist forest that has maybe 10 to 11 months of the year, a lot of rain. So there's a lot of prone to mudslides and difficult, it's very difficult to move around. So it's the people we serve are our bosses, which are the patients that we work with. They usually live in very small communities of around maybe 1,500 to 2,000 people spread around all of this mountainous region. So each community is around maybe 1 hour, 2 hours away from each other. And usually transportation is really hard to come by. So most of our patients are coffee growers, and coffee is an interesting way of living because it is a commodity. So you only have access to the resources depending on the market. So depending on how much coffee there is around the world is if you will get more resources or more money in exchange for your coffee or less. And it's usually like a 1 year, sorry, I forgot the word, a 1 year crop. That's the word, a 1 year crop. So you usually have a population that can only have access to resources once a year. And then they need to be able to manage those resources during the rest of the year without really knowing how much money they will get the next year. So usually coffee growing season is around January, February. People get their resources and then they try to maximize it throughout the year. By November, December, they start already asking for loans without really, it's really hard to know or manage your resources when you don't know how much money you will get or if the weather will change and that will affect your crops. And also interesting characteristic of our population is that it is a population that historically comes from an indigenous group called the Mam. But in Mexico, there was this strong idea of making Mexicans Mexican. So ripping their cultural traditions and changing them to what we would call mestizos or a more Mexican perspective. So a lot of the population we work with has been ripped off or of their historical ancestry, and that of course creates a lot of generational trauma seen from our perspective. Yeah, so a normal day for a coffee grower would be waking up around 4 in the morning. Women will usually start preparing tortillas. It's a very long process, and making breakfast and lunch for their spouses. Men will get everything ready to go to their fields where they have coffee, corn, and beans. Corn and beans are mostly to have food at home. Since the NAFTA treaty, corn and beans are not sold in Mexico very much. You can't really get a lot of resources for that. So it's mostly for consuming them at home or eating them at home. Women will stay home with the chores, taking children to school, washing clothes, and cleaning their houses. After 4 p.m., usually men come back. We're talking about the fields are usually 1 hour, 2 hours away as well, and they usually walk to the fields, or maybe some have motorbikes. But usually it's a walking process. And after 4 p.m., they usually come home, enjoy some time with their children, and with the sunset, they go to sleep. For children, usually they have school, but the truth is that is very often that they don't have school, that teachers don't show up because it's really far away. And usually teachers and healthcare providers travel back and forth. So it's very common for children to miss school or not have school and stay home. And yeah, that's usually a day for some of our bosses in our daily lives. Yes.
That's fantastic. Thanks, Val. Melino, same question to you. Tell us about the people who make up PIH Lesotho and our bosses and the population you serve. And which, speaking of last mile health services, you know, the catchment area that you work in extends over many, many, many miles. Very, very hard terrain.
Yeah, thank you so much, Mark, and thank you everyone for joining the discussion. I am Melino Ndayizigiye. I'm the executive director for Partners in Health in Lesotho. PIH Lesotho is made up, of 430 staff members and 191 treatment supporters, and over 98% of our staff are Lesotho from all over the country. And for those who don't know Lesotho, this is a beautiful country, landlocked inside South Africa. It has tall mountains, and it's actually the only country in Africa where we have snow, like Canada. So our bosses are our patients. We have patients in rural, hard-to-reach areas. That's where we started our operations in 2006. And at that time, we were invited by the government of Lesotho to provide HIV services to those remote, hard-to-reach communities. And we quickly realized that it's not possible to provide, to improve health outcomes if we only focus on HIV care. Then we started to expand our services to integrated primary health care services, treating TB, maternal child health conditions, immunization. We have hired staff. We equip the facilities with modern medical equipment. We make sure that we have systems in place, including electronic medical record, transport system using, different means of transport. Sometimes we have to hire, helicopters for emergencies. And in 2007, we realized that, Lesotho was facing that time high burden of multi-drug resistant tuberculosis. And we started a program to treat multi-drug resistant tuberculosis. In this program, we receive patients from all over the country. Actually, Ryan was yesterday in Cotrongre, and this is one of far remote districts. And we see patients who are very, very sick, the most vulnerable. Most of them have, have been experiencing this resistant TB, drug-resistant TB for quite a long time, and they got very sick. And in 2014, we expanded our work to include health system strengthening using a model of care from our rural supported sites. And we expanded our programs in 4 districts. And the program has yielded in, big impact in terms of uptake of primary healthcare services, maternal child health services, HIV, and so forth. And we realized that, again, we need to go to another milestone. We started integrating mental health services into primary health care and MDR-TB. And all has been going very well. And during COVID, we were facing, a challenge of not having enough oxygen. And actually, Lesotho has been importing oxygen from South Africa. And we were the first organization to establish a PSA plant, an oxygen plant, to produce medical oxygen locally. Now we are even expanding our oxygen production capacity, and we have been distributing oxygen to over 20 hospitals in the country. So in summary, we have been, adding more programs and keeping the momentum to deal with the most critical needs of the country. And even recently, we started to support the cancer program, which is a new program in country, and with our partnership with Dana-Farber and the University of Pennsylvania, we are supporting the cancer program in Lesotho, and we see already good progress in terms of improving treatment outcome. Thank you.
Yeah, thank you, Melino. It's amazing the work in both countries. The progress has been unbelievable, just even in recent years. So Ryan, yeah, it's so wonderful to have you here as well. And as you know, this is back home. This is International Development Week. And in some ways, if we had our druthers at PIH, we would call it Solidarity Week or Equity Week. Health equity in our case, of course, because anywhere in the world, we know it's the inequities in access to care and to the conditions that keep people healthy, the social determinants of health that you have written a ton about, that are the biggest drivers of illness. I'd love to hear your reflections on being in Lesotho now for a couple months, what you've seen as a physician, and how it may be similar or different to what you see and deal with back home.
Thanks very much, Mark, and thanks everyone for joining today. It's been such an honor to get to work with the team here in Lesotho. It's a remarkable operation, and I'm learning more about it every day. Slowly but surely getting a better sense of the country and all of the work that PIH does here. I'm here with my whole family. My wife is a pediatrician. I'm a family doctor, and we have 2 kids. Gus is 6 and Abe is 12. So they're experiencing Lesotho in a totally different way. They're going to school and making friends and getting in trouble and learning swear words in Sesotho and all the things that kids do. And Meili and I are working mostly so far with the MDR-TB program, but we're looking to be working more with the rural initiative and supporting the health systems side of things as well. I've been thinking about, so back home, we're TB doctors as well. So in northern Saskatchewan, there's high rates of TB, and both of us fly up to northern communities to do clinics. And I was thinking about how that is very different. And we have in Lesotho all of the mountains, and Saskatchewan doesn't have a single mountain. So very different landscape, very different territory that we go over, but there's also a lot that's the same. On a regular clinic day in Saskatchewan, we go with a X-ray tech and a nurse and an MOA, a staff person, receptionist who helps book patients in. And we fly up and we do a blitz clinic, seeing all our TB patients in the day. Here, go with a driver and 2 community nurses and a doc and a pile of stuff, lab equipment to take blood samples, meds, the ECG machine, all of those things. So it kind of feels like the same thing. And some of the perceptions are the same too. And you talk about equity and the things that drive what makes people sick or well, and have the same reflections here as there. We talk about with PIH, and with most of the time when we talk about health, it's easy to think about the health services, the doctors, the nurses, the hospitals, the clinics, and those things are very important. And I really admire the way PIH insists that the care that they provide should be equivalent to the quality of care provided anywhere in the world. That's really important. But it's also important to remember that it's not in the clinic that you get sick. It's in the forests of Chiapas, it's in the mountains of Lesotho, it's in people's real lives. And it's whether people have a chance to go to school, whether their crops will sell, whether they've got a safe place to stay, whether they've got enough to eat, that makes the biggest difference in whether people will be ill or well. And I was thinking about one big difference between those traveling clinics in Lesotho and Saskatchewan. In Saskatchewan, I bring a box of Tim's for Melino and Valeria. Tim's is a donut shop. So we bring a box of donuts for the staff that don't get that in the remote communities. They're happy to get it. Here, the back of the truck is full of bags of maize flour, sorghum flour, sugar, oil, all going to the patients and their treatment supporters so that they're able to feed their families. And I love that about PIH, that they recognize that it's not enough to go with a box of pills if people don't have anything to eat. It's not enough to just show up and take x-rays and say, here you go. And knowing that if people have enough to eat during their treatment, they're more likely to recover from that treatment, but also they and their family are less likely to get sick with other things. And I love how that's a baked in part of the program, and that we're constantly having discussions with the team about, is that enough? And are there other ways that we can support families more broadly so that it's not just those individuals that got sick that get help, but we can help keep people healthier in the long run.
Thanks, Ryan. That's wonderful. It's so interesting to hear those reflections and the similarities, and yet the additional pieces that are needed everywhere in order to really ensure that people, as you say, not just the medical care, but all those supports so people don't get to critical stages. Val, as you know, again, and are a leader in so many things, and one of them is this. One of PIH's top areas of focus is the health and rights of women, including sexual and reproductive health and rights. and Chiapas has one of the highest rates of maternal mortality in Mexico, due in part to the lack of access to quality medical services and decent treatment. And yet we know these services are rights, but often not delivered on. What specifically do you think needs to change? And can you give me examples of what your team is doing to drive that change forward where you work?
Yes, thank you, Mark. So as Ryan was mentioning, I really want to bring forward the framework that we always use at PIH to creating any program we're thinking about healthcare. And it's the 5 S's framework: staff, space, systems, and social support. I think that's very important for all of us when we're thinking about how can we really impact in people's lives to make a change in healthcare. Some of the things that we're doing in Chiapas to try to impact in maternal mortality is we really need to have healthcare services available close to women. So talking about being in a mountainous region and people being really far away from larger cities where usually hospitals are, in Companeros and Salud, we started a project called Casas Maternas, which is birthing centers, in where it's more of like a first level of care service that we really try to make it be close to women, so women don't have to travel a lot. We've seen that the closer women can have access to services, the more they will be able to reach out to those services. So in the birthing centers, we have midwives and professional midwives and obstetric nurses who are leading the place, running the whole thing. They provide services with what we call a midwifery model, which is a model in where women are respected and are the ones that have complete autonomy of their delivery. So they decide in what position they want to deliver, who they want to be with when they deliver, who they want their provider to be. So it's very woman-centered. We really believe that you really need to have spaces close to women and support them with everything related so that they can have access. What I mean with that? So what I mean with that is that we really need good referral systems, emergency care, and to be able to transfer people to higher levels of care when they need it. What we do is we have our birthing center, but we also have a housing available so that women can come with their children, with their families, and be there in the waiting for their deliveries, because you don't really know how long it will be or when you will be delivering. So it might be 3 days, 4 days before they actually start their process of delivery. And because they're so far away, it's really hard for them to travel once that happens. And because they do have some of them have children and they don't have, who will take care of those children, by providing them food, transportation, and a housing, then they have a lot more access to the services available. A lot of women deliver at home, and the problem is when they deliver at home in this specific context or region, it's really hard to get them emergency services because they're so far away. So we know that usually births happen okay and they have no complications, but some of them do get complicated. And if they do get complicated, then you need to have an ambulance ready, you need to have an OR ready, an operating room ready, you need to have everything ready to really be able to stop that woman from dying. So by creating that whole system, it's how you can really impact on women's healthcare. So that's why we created this model of Casas Maternas, in where it's a safe place for delivery and has those connections to higher levels of care when required, and has all the social support required so that women can actually be able to travel and they don't have any limitations to be able to receive care in a facility. Yes. We've also strengthened the surgical room in the basic community hospital nearby so that we can have access to surgeries when a complication arises.
That's fantastic. Thank you. And it's amazing how, part of Partners in Health is learning from other sites. And I know their maternal waiting homes in Lesotho has been critical to the work that Melino's team has done in reducing maternal mortality. There's the similar structures in Haiti and in many other places we work. So yeah, Val, as you said, those 5 S's are just so important to be able to build that system and bring care closer to where patients are. Melino, you touched on TB, and we're talking about TB a lot within Partners in Health, and Lesotho is always right at the top in terms of what the country has been able to do and what you and your team have been able to do. TB, is the world's largest infectious killer, and yet it's a preventable and curable disease and kills 1.5 million people a year. What allows you to treat tuberculosis and multi-drug resistant tuberculosis and to make advances in Lesotho, one of the countries with the highest prevalence rates in the world? And what are you most proud of in terms of what your team has been able to do?
Yeah, thank you, Mark. Yeah, indeed, TB is the top killer among all infectious diseases. And in Lesotho, it has actually been, Lesotho has been ranked like among the top high TB burden in the world. In fact, according to the recent WHO report, the TB incidence in Lesotho is the highest in the world. And this is contributing to a lower life expectancy in Lesotho, which is one of the lowest in the world with 53.7 years. And you can think, Canada, the life expectancy I was checking is, over 81 years. So Lesotho is like 30 years below Canada. And this is one of the reasons is because of TB. And again, looking at the recent WHO report, in Lesotho, TB is, killing so many patients, so many people, young people, adults, and unfortunately, only a third of the TB patients is diagnosed. 2/3 of the TB patients are not diagnosed and or put on treatment. So we've been thinking and supporting the Ministry of Health to come up with innovations to try to, reduce the TB burden. And some of the intervention that we have, initiated with the collaboration of the Ministry of Health is the introduction of point-of-care technologies and artificial intelligence and telemedicine. And when we introduced these technologies, 2 years ago in our rural supported sites, we have seen, a 4 times increment in terms of TB case detection. And the Ministry of Health and the government and all supporting partners, they realize that this is the way to go. We need to rethink how we screen for TB. We need to rethink how we introduce, point of care testing, technologies like gene expert machines at the health center level, digital X-ray machines at the health center level, and even at the community level. And this is what is making impact. And I'm really proud of this because we see already like the Ministry of Health, scaling up similar interventions in the rest of the country. And I'm confident that in the next, 2 years and so, the TB burden, Lesotho will not be ranked among the top TB burden countries. Thank you.
And bravo to that. That's, yeah, we continue to see and hear about that progress, which is just amazing. Ryan, we've chatted a ton, and you have read certainly one of the co-founders of Partners in Health that we all follow and love and remember fondly, Paul Farmer. You've read a lot of Paul's works, and so even way before coming to PIH Canada, to Partners in Health, you kind of, on an academic level, certainly understood what the DNA was in a whole bunch of ways. And Val mentioned the 5 S's. You touched a bit about this earlier, but I'm wondering, from knowing kind of the theory and kind of how PIH was built to really seeing and living, what else has stood out to you about now having the experience of what you've read and known and learned about for so many years?
Well, that model of the 5 S's is such a deceptively simple way of describing how health systems work and what is necessary to provide great quality healthcare. And I think it's a really helpful way of thinking about things: the staff, the stuff, the space, the systems, and the social support. I was thinking a little bit about what I've seen of examples of that now working on the ground in Lesotho with PIH. And the first thing that struck us as soon as we got here was the staff. When you meet somebody, what's your name? How long have you been working for PIH? And the answer was never like, I just started last month. It was, I've been here for 5 years. I've been here for 10 years. I've been here since 2007. And that level of dedication and attachment, and the way that people spoke with pride about their work and about the values that underpin PIH really spoke to us right as soon as we got here. And that goes from some of the best docs I've worked with anywhere in the world, to the treatment supporters, the people who come to every appointment and go to the patients' houses, make sure they have what they need to continue to take their treatment. It's a project-wide, organization-wide set of values that are really shown in the people above all. And I think that, I could stop there, because that's, to me, probably the most beautiful thing. But there are other things I'll mention. One is, I previously worked in other settings. I worked in Mozambique and other low-income countries, and it was often a real frustration to try to provide care and feel like your hands were tied. The equipment wasn't there, the stuff and the spaces weren't there, the medicines weren't there. And here, there are still challenges. It's not easy to get everything, but when we need to give a patient what they require to get better, when we've got our MDR TB patients at Botshabelo Hospital, and dialysis was something we needed for a patient last week, that's a really challenging thing, and it's not cheap. And the leadership here said, will it make a difference? Could it help this patient make it? If the answer is yes, then we try. And that, to me, is just, it's mind-blowing, having worked in places where the answer was just, I wish we could, but we don't have the resources and we can't try. And I know, PIH is special. We have the support of our donors, and please keep that support coming in, because we're able to provide more. But it doesn't stop with PIH, and that's the last thing I wanted to say. And I think there's maybe a missing S about what PIH does that's special, and that's sharing. So take, for example, what Dr. Melino talked about off the bat. We didn't have oxygen here during COVID because South Africa wasn't shipping oxygen because they needed it at home. And Lesotho didn't have that capacity in country. So what did PIH do? They built an oxygen plant because their patients needed it at the TB hospital, multi-drug resistant TB hospital in Maseru right away. That was the primary thing. Then they realized, we can't keep this for ourselves. This can't just be for Botshabelo. It's got to be for the whole country. And now, as Melino pointed out, it's being provided to 20 facilities across the country. And this is one of the things I love about PIH. We work in, is it 12 countries? Don't want to get that wrong. 12 countries. That's a pretty small number of countries in the world. But the things that PIH does get picked up and translated into other organizations and the health systems of governments. The work in Peru, and the initial first place that started treating MDR TB in the world was PIH. That changed how it's done around the world. The impact on HIV care the work that's going on, the innovation that's going on through PIH on the ground doesn't stick with this organization. It spreads and makes a difference in the lives of patients everywhere in the world. And that's what pleases me so much about working with this organization.
Well, that's fantastic. Thanks, Ryan. And that's a great segue kind of into the next little section, and we'll get through this pretty quick because you still want to have tons of time for questions. But start with Val and then to Melino. As you both know very, very well, care delivery is just one part of our theory of change. And another part is, as Ryan mentioned, using the success of Partners in Health to not just within country, but to help change national and global policies about how we do this work of global health equity. So maybe we'll start with Val. Is there one policy change that would improve the lives of your patients, either national level or how the global health community operates, that would benefit patients in Chiapas? Any thoughts on that?
Yeah, I think in other countries, this policy has already been implemented, but I think in Mexico, we're still behind a little bit. One of the things that we really are working on, and I feel that this is something that's a model throughout all of the different 12 countries in we work in PIH, is showing evidence that task shifting models work and that it's really needed, especially in rural areas. I think healthcare is a very medical centric I'm going to say area of work, and a lot of the times that takes us to not valuing enough or really bringing forward all the things that people can do in healthcare. And when I talk about that, I mean community healthcare workers, for example, have been people that can really make a change at a community level and impact healthcare. And usually in many places, this is undervalued, or it's not recognized the impact that it has to be living there with your patients and being part of the community and understanding the community and then being able to provide care. So we are trying to work a lot in showing the evidence, for example, of community health workers providing mental health care in rural communities, and how this is more impactful than a lot of times doctors providing healthcare, because community health workers stay there, they work there, they live there, and doctors usually have a high rotation in these communities. Or, as I mentioned before, they're not always there because they travel back and forth because usually their families are somewhere else. And also not only community health workers, but nurses. In Mexico, we're really trying to also impulse nurses to be able to do what we call the advanced nursing role, which is, we don't have nurse practitioners in Mexico. And I think in many countries, there's still that gap that nurses, which a lot of times are actually members of the community as well, can be able to do a lot more and are respected and are recognized as being able to do a lot more. So, for example, in Companeros, our nurses are being able to provide follow-up care for chronic care patients, diabetes, hypertension, so that also, as the community health workers, they're usually members of the community that stay there, that live there, and that know the community for a long period of time. So usually this provides a higher impact in healthcare than someone that is from another city that recently moved in and is providing care without really understanding the patient or the community. So I think being able to make this policy change in where nurses, community health workers are recognized and are paid to do this work would be something that would really impact rural areas and healthcare in Mexico, and I think in many other countries.
Fantastic, thank you. Melino, same question over to you quickly. What in Lesotho would really have a greatest impact in terms of policy change, global funding, health policy? What comes to mind?
Yeah, thank you, Mark. I also think that you know, policy on social support and investment on social support will make a huge impact, especially in countries like Lesotho and any country, any low and middle income country. I can give you a few examples. For example, we deal with TB patients, right? Who are very weak, who have been made very sick because of this disease. Even if we give them medications, they might not improve because they don't have, food, for example, right? It's the same as, pregnant women who need to come to the facility and give birth. They might not be able to come because there is no food while they are waiting to give birth. So I think a policy and investment in social support will make a huge difference, especially when you think about improving health outcomes of the most impoverished communities.
Yeah, fantastic. The fifth S that needs to be universalized. Absolutely. I would now encourage people, if you have questions, please put them in the chat. We'll get to it right after one final question to Ryan and last one to you before we open it up, and we'll take questions. One question, as you know, that we hear a lot, we have huge challenges for equity at home in Canada, and you see it all the time, both in Saskatoon, both up north. Given that, why should Canadians care about global health, international development?
I think that question strikes to the heart of why Partners in Health exists and the values that underlie this work. And to me, it comes down to a simple philosophical belief that everybody's life matters. And whether it's the herd boys with their sheep in the mountains, or the girl selling apricots by the speed bump in Maseru, or the guy who's wasting away in our hospital in Botsabelo and needs help to gain weight again, or the little baby I examined yesterday in Mohotlong who is 6 weeks old, has HIV and doesn't have a mom because of HIV. Their lives matter as much as yours, as much as mine, as much as my kids. And that's a fundamental belief. And before anything, I call on people to think about that, to think of the words of Paul Farmer, that the idea that some lives are worth less than others is the root of all that's wrong in the world. Start there, if you can. If you can't, then self-preservation, right? If we look at the rest of the world and it's going to hell, our lives are not going to be good either. And that's true in Saskatchewan and Canada. If my neighborhood or northern Saskatchewan, if people are really in trouble, well, there's more crime, there's less safety, there's more draw on our public services. Same is true if the people who are struggling are on the other side of the world. Look at COVID. How fast did that spread all around the world and continue to spread and change because we weren't able to, or some chose not to provide vaccines equitably to everywhere that needed them. It doesn't stay in one country. And in a world of growing conflict, climate change, of refugee crises, if we want our homes to be safe and good, we should make sure that everyone's home is safe and good. That's how we build relationships with other countries. That's how we establish the kind of world we actually want to live in, which, back to that point, to me, the kind of world I want to live in is one where everybody's life matters.
Thank you. We have a couple questions. I'm going to ask two of them right now, and the first one we'll give to Melino and the second one to Val. So Melino first. In Lesotho, what aspects of primary care does PIH provide? Episodic care of acute illnesses, chronic disease management, preventive care such as vaccinations. So just elaborating a bit more on what the scope is on the primary care services. And then one for Val, and then Ryan or Melino can jump in as well. early on, pre-hospital care and getting patients to care if they need to travel to care was mentioned. Can you just elaborate on how that works in your community? How does that transportation accessing care work? Is the pre-hospital care, including ambulance service, integrated into regional and national systems provided by government? Or is that something that just PIH does? And if so, how do we accompany government to be able to strengthen those services? So Melino, you can jump in on the first one. That would be great.
Thank you, Mark. The kind of services we provide to our bosses include, preventive and curative care. On prevention, we provide, immunization. We give. We also treat acute and chronic illnesses, including OPD, inpatient, and we're also providing chronic care for non-communicable diseases, both communicable and non-communicable diseases. And we have a big cohort of patients on chronic care, and we make sure that those patients receive quality health services. And we not only provide facility-based care, but we also go beyond the facility and we conduct outreaches, and we work with a network of village health workers at the community level who help us to do like community health education, patient accompaniment, door-to-door surveillance. So we do like a comprehensive approach. We have a comprehensive approach to primary health care to make sure that no one is left behind when it comes to uptake of essential health services.
Thanks, Melino. And Val, over to you.
Yeah, transport. That's a tricky question. It's a challenge. And we're definitely talking about the last mile, right? So I can divide this in different sections. So for sure, hospitals that belong to the Ministry of Health have usually an ambulance. The complication about healthcare sometimes is all of the relationships that need to come together and interact and work together to be able to be successfully. For example, in Mexico, you have the Ministry of Health, you have the municipality, and then, for example, in this case, you have Companeros, right, an NGO. So you have all of those three institutions working together to make it work. For example, the ambulance in theory is from the ministry, but the gasoline and the driver usually comes from the municipality. So a lot of the times, and I think also the services for the ambulance to be, up and ready to continue working. So actors have to be continuously working together and getting and making decisions for a transport system as the ambulance to work. So you can imagine how complicated that can get. We definitely work hand in hand with the Ministry of Health, and we support in that gap that maybe the ministry or the municipality is not able to reach at that point of time. If there is maybe gas missing, or if the ambulance is not working, and then we need to support with some services so that it can work. Or maybe sometimes they ask for a driver and we provide a driver for a day or two. So it's a constant collaboration. We've had also cases in where there is an emergency at the community, and as Melino said, we have to call for a helicopter. In this case, most of the times the actual Ministry of Health is the one that provides this with a good collaboration. I think the biggest challenge is in that last mile from the hospital to the community. And that's where, as Melino mentioned, usually there's no policies for social support. So that is the biggest gap that we have. So how do we help or support patients that are in the community be able to move to the facilities that a lot of the times are 2 or 3 hours away? So that's where also PIH or Companeros and Salud brings a lot of support. We usually these bosses don't have actual cars or motorcycles or any way to move around. There's usually one public transportation that's usually a truck, a 4x4 truck of the community that has sort of been adjusted to transport patients on the back, and that's how people move around. And sometimes it's available, sometimes it's not. So we definitely try to support patients with we call them gas vouchers. Is that, yeah? So that they can have a payment to give to this public transportation that's available to move around. And that's why sometimes we need the housing, so that they can maybe come 3 or 4 days earlier, because you don't know if that same day you'll be able to get some transport. So I think that that last mile is the one that's more complicated. And as long as our ministries of health or our government doesn't have social service, social support as a policy, then we still have that last mile that it's the hardest to reach to. And then that's where we really try to put all of our efforts to really complete our mission of preferential option for those that need it the most. So I think that's where we still need to work a lot with the ministries or the government to be able to show how, and it is already published, right? The biggest economic gap or the biggest spending is usually from transportation, food, and moving around, and not always the medical costs, but the out-of-pocket expenses that are non-medical are the ones that are taking our populations towards impoverishment. So addressing that needs to happen by our governments to be able to reach that last mile of the population.
Yeah, thank you. And then another question here that kind of follows up on what you were saying, and it's something that we think about a lot in PIH, but would love to hear, Melino and Val, again, your perspectives. And we have probably 5 minutes total, so we'll get through as much as we can. What challenges are there, or are there challenges in getting ministries or donors to invest in these hard to reach areas, which is really the places where we work? We don't really work in capital cities necessarily, mostly rural, because governments or donors might feel that there is a better return to focus on urban populations where you can have much larger numbers. How do you think about that in terms of the work that you do? Maybe Melino and then Val, if you have any.
Yeah, thank you, Mark. Yeah, it's true. There are not many organizations working in hard to reach areas, because working in hard to reach areas, it is very difficult. It requires not only funding, but strong commitment to social justice. You know, some of the organizations focus on urban area because it is easy to move around. But if you, Val was talking about how difficult it is to move around in Mexico. In Lesotho, it is even harder because patients have to travel on horses and climb mountains up and down. For organizations, if you think about, working in those areas, you have to be ready to, to face those challenges. And, moving around, it has, huge cost implication. Even supplying medication, staff, and equipment, it is not easy. So I think it is about, an issue of equity, and also being mission driven to serve the underserved communities. Thank you.
Yeah, for me, I would just like to maybe share an anecdote that I lived while doing some of my research in surgical care in Mexico. So Mexico, it's a huge country. It's an upper middle income country. And I think that also shows the inequity that we have within our country. It's not the same talking about healthcare in Mexico City than talking about healthcare in rural Chiapas. And the gap is, I'm going to say, tremendous. It's huge. The interesting part is that when talking with government officials, I remember a lot this phrase of like, oh, well, Chiapas is a different story. Chiapas is different. It's not Mexico. So a lot of the times we don't even realize our unconscious biases. And I mean, what that phrase showed me is that, yes, it is a challenge to be there, and it's completely, maybe there's just too many challenges to face. So it can even be overwhelming to even think about how to solve the problems of healthcare in Chiapas compared to other places in Mexico. And it was sort of putting a blind eye to that part. It's like, well, we're doing a lot more in other places, but this one is too complicated. So yeah, I think sometimes making it so challenging can be overwhelming, and it's easier to not think about it, or give it that blind eye of like, but look what we're doing in other states. But we're still Mexicans, right? And we're still human beings, and I think I'm gonna go back to that preferential option to the most in need, and that I think that's why I fell in love with with the PIH mission, because it's actually changing that perspective and saying like, well, it's actually those places that are the most challenging and where inequity is the biggest, where we actually need to focus more time and energy towards, instead of being like, well, we'll get there sometime, we get there someday. Yeah. So thank you for the question.
Thanks, Val. And I think that we're actually time for one more quick question from Melino. You had talked, and probably we just have 2 minutes for this. Someone is curious to know more about the cancer work. You said you're just starting. What kinds of cancer is prevalent, and how are you able to do this in 2 minutes?
Yeah, thank you, Mark. Yes, Lesotho has started a cancer program. Before, Lesotho has been referring cancer patients to India and South Africa, and you can imagine, like, the medical bills is just huge. And recently, Lesotho has started the program, and now there is one oncologist, a native of Lesotho, and there are many patients. And as PIH, we realize that there is an urgent need to support Lesotho to establish this cancer program, and we made partnership with Dana-Farber Institute in Boston and the University of Pennsylvania. They are sending us oncologists, oncology nurses, pharmacy oncologists, pathologists, to help us build local capacity, and also treat these patients who are in dire need of care. So the country has started with solid tumors like breast cancer, prostate cancer, and other solid tumors. Right now, they are being managed in the country, but the non-solid tumors are still being referred to South Africa. But the plan is to have all cancer patients managed in the country, and the government is investing in building a cancer center where there will be like radiotherapy and also chemotherapy. So this is maybe in the next 1 or 2 years, the building will be complete, and I hear it's one of the top priorities of the Ministry of Health, and I believe very soon the cancer care will be of high quality in Lesotho.
Amazing. It has been so amazing to hear of all the work over the past hour. I just want to say a huge thank you to Val and Melino and Ryan for spending parts of your day or evening with us. We really appreciate it. Most of all, thank you to everybody who came out to listen and ask questions and be a part, and so many of you who have been incredible supporters of Partners in Health's work for a long time. We are eminently grateful, deeply appreciative of all that. And on that note, because of in order to support the work that you've heard, we really do need your support. If you are able to contribute to this work, we would be so appreciative. You can visit pihcanada.org/lastmile. And if you have any questions or comments, please write to us at pihcanada.org. Paul Farmer often said, you know, this work, we've heard a lot about challenges, but this work is also doing hard things with friends. It's a privilege to, and we heard that from Ryan too, about people in Lesotho, how long they've been there doing this work together. That's what sustains us. Our supporter and donor community sustains us. Thank you so much. Have a great rest of the day. pihcanada.org/lastmile, and happy International Development Week. Thanks for coming.
Thanks, everyone. Good night.
Thank you. Bye-bye.
Thank you for your time.